My name is Dr. Clement. I'm here to speak to you today about how do we lose our vision, or perhaps how do our patients lose their vision when they are HIV infected. You know, this deficiency of the immune system is all that matters. Because when the CD4 count is low, there's a tendency of proliferation of viruses which disturb our vision. The example that I have is cytomegalovirus. It targets the area in our eyes which is sensitive to light, and that is the retina. So we don't want any retinopathy. In other words, any pathology in the retina. No. Because that will directly disturb vision. So inflammation of the retina is what is known as retinitis. So cytomegalovirus retinitis is accompanied by loss of vision, is accompanied by blindness, so to say. Patient loses the visual acuity. The patient starts saying, hey, I can't see, I'm losing I don't know what's going on. Then you know that, number one, the CD4 count is very low. Number two, that the opportunistic infection that is actually towering over everything else now is cytomegalovirus. So the patient is actually having what is known as cytomegalovirus retinitis. Retinitis, you know, I like saying that. Because I'm saying inflammation of the retina. Can the retina afford to be inflamed? No, the answer is no. Because what are you saying? I'm saying the retina is going to go red. Rubor. You know, what am I saying? I'm saying that the retina will have what is known as dolor. You know, pain. You know, what am I saying? I'm saying that the retina is going to have calor. You know, development of heat. You know, what am I saying? I'm saying that the retina is going to develop tumor development. Those are the characteristic features of inflammation. And when you say retinitis, so to say, that's what you're saying. You're saying all those four will be there on the retina. And then we expect that retina to function well. There's no way that the retina... In fact, blindness. Patients go blind with the retinitis. You know, cytomegalovirus retinitis. This is something to be taken home. Cytomegalovirus retinitis. What is the one that follows that? That's number one that causes with patients who are HIV infected, that causes blindness. That's number one. Cytomegalovirus retinitis. What is the next one? The next one is toxoplasmosis. Toxoplasmosis retinitis. Toxoplasmosis is one of these opportunistic infections that you find with low CD4 counts. You know, there's an organism known as Toxoplasma gondii. Toxoplasma gondii. So it causes the toxoplasmosis. So toxoplasmosis, that's the one that one we can actually test for it. And you know, toxoplasmosis gondii. The next one that follows is what is known as ocular syphilis. So the Treponema pallidum actually gets into the eye. Oh no. ocular syphilis. You know, Treponema pallidum will always cause syphilis. It doesn't matter where. Whether it's in the genitals, where, it will cause syphilis. So we have now syphilis right in the eye, ocular syphilis. This is bad news. So that is what we are worried about. Is that all? The HIV itself causes what is known as, cotton wool spots. Cotton wool spots right on the retina. Right on the retina, you've got cotton wool spots. How is the retina gonna facilitate our vision? It's not gonna be able to do that. Cotton wool spots caused by HIV itself. This is a problem. This is definitely a problem. So what you should have in mind is that what causes our vision to go is retinitis caused by cytomegalovirus. Is retinitis caused by Toxoplasma gondii, which is toxoplasmosis. Retinitis caused by, by syphilis, ocular syphilis. Call it, the whole eye, the eyeball, being full of, the Treponema pallidum. Those are the agents which cause syphilis. And you remember, we said this can lead to, meningitis, syphilitic meningitis. Hey, no man. Syphilitic meningitis. I mean, once you say meningitis, already you're saying inflammation of the meninges. Inflammation of the meninges will mean that an increase in the intracranial pressure. And once there's an increase in the intracranial pressure, you're worried about one thing. You're worried now about the development of papilloedema. Papilloedema, you can't expect vision to be perfect. There's no way. Papilloedema. This is a problem. Increased intracranial pressure from syphilitic meningitis. When you say meningitis, how do you expect? You're expecting the same thing, the rubor, the redness of the meninges. What do you expect? You're expecting the generation of heat calor. You're expecting the dolor, pain, generation of pain. You're expecting tumor, the development of a tumor, the swelling, so to say. This is not good stuff. That is for sure. So we've got to devise ways and means of making sure that this doesn't happen. And this you get whenever you have a low CD4 count. From where? From HIV infection, which knocks the immune system. I need just to go on a little bit, just to say something about this loss of vision. There's another condition known as PML, progressive multifocal leukoencephalopathy, PML. This is caused by polyomavirus. Polyomavirus, the example that we use, they often known as the JC virus. It's a polyomavirus. And the partnership of this polyomavirus with HIV, it's a mess. It's a mess because the polyomavirus or the JC virus targets the cerebral hemispheres, the left and the right cerebral hemisphere. You know that the cerebral hemispheres, they are covered with a sheath, and this sheath is known as the myelin sheath. Even the neurons are actually covered by this sheath. Neuron, the myelin sheath. Now what happens whenever there is this polyoma virus, which you get you get it in all cases. You always find it whenever the CD4 count is very low because of HIV. When the CD4 count is very low because of HIV, you get this. You get this polyoma virus or the JC virus. You know what it does? It targets the cerebral hemispheres consists of the gray matter and the white matter. And then it targets the white matter and it demyelinates it. It removes the myelin sheath, the one that covers, makes the neurons to be safe and conduct impulses well without any interference or intervention of anything. See, because they're well covered by the myelin sheath. Think of a situation when this myelin sheath is removed now. There are patches of demyelination. That's why we call this a progressive multifocal leukoencephalopathy. It goes straight to the white matter and it demyelinates it. And this is a mess because remember, it's covering what? The cerebral hemispheres. They're covering what? They're covering sensory cells as well as motor. They're covering sensory neurons and motor neurons. Now, if the motor neurons are naked, they are not covered, they are not going to be able to carry out the motor function. Motor function is movement and all that. They are not going to be able to do that. You find now the result of this is weakness, this demyelination, these patches of demyelination. They cause weakness, the motor weakness. They cause dementia. They cause ataxia. Ataxia, you look at the gait of the patient. The patient wobbles around because a loss of gait. The gait is not there. So they have a condition known as ataxia. And this is bad. This is bad because of multifocal. The very, very last, very important thing. Remember, we're looking at how do we lose vision. You get what is known as cortical blindness. Cortical blindness. The cortex, which has all the motor neurons, and it has got all the motor neurons which control our vision and all that, our eyes and all that. So that is lost. So this is the big problem. Multifocal. You can remember, you can forget all everything else, but you're going to remember that the multifocal, actually, the progressive multifocal leukoencephalopathy. When you say progressive, you really mean to say it's progressive, because those patchy removals of the myelin sheath, those demyelinations, they are progressive. They are going at a faster rate. And these patients, they end up, they get into a coma. And after coma, you can only think of death. And after diagnosis, they live for something like 6 months. So it's often very difficult to make that diagnosis. Healthcare workers, we've got to be mindful of this. That if you have a patient who has a cortical blindness, it is the cortex that causes the blindness, then that is multifocal. That is a progressive multifocal leukoencephalopathy. This is something that we have to worry about, and this is how we lose our vision. We lose our vision because of these ones. And I would love to make sure that these conditions you go over them slowly so that you understand exactly what is happening. You know, yesterday I was emphasizing the fact that syphilitic meningitis, you get it because of problems with early neurosyphilis. When do you get this early because of mismanagement of early syphilis. If you mismanage early syphilis, you don't give what you're supposed to give. Well, of course, for syphilis, you have to give this benzyme penicillin 2.4 million units. You've got to give that, and then to make sure that you don't get. But because of the problems that we are encountering, now the decision is made that add amoxicillin 500 milligrams TDS. Make sure that you add ceftriaxone, the Rocephin. Add Rocephin. You always give 1 gram BD. So just make sure that you, in addition to the benzyme penicillin, because there are problems with this. There are problems. Sometimes, remember, we spoke of, we're talking about syphilis, syphilitic meningitis. In syphilitic meningitis, there's a problem of the actual treatment, the loss of sensitivity to the treatment. This treatment that I'm talking about, this benzyme penicillin, the patient just doesn't respond because of a low CD4 count. The patient just doesn't respond. That's why you have to use things like amoxicillin in addition to the benzyme penicillin. And you have to use Rocephin, that's a ceftriaxone, 1 gram BD, to be okay, just to make sure that this patient, because really they don't respond. I mean, this is sad. HIV, making sure that the response to the treatment, I mean, you start doubting now, is the diagnosis correct? Did I isolate the actual Treponema pallidum? If it's isolated, here is it. But why is the treatment not working? Why is it insensitive? That is why you have to aid and make sure that things are. We have another condition which we normally compare to HIV dementia. It's known as Creutzfeldt-Jakob disease. The difference between the two, well, you will find that with Creutzfeldt-Jakob disease, you will have problems that are similar to syphilitic meningitis. We'll have problems which are similar to that type of meningitis. And also they are similar to HIV encephalopathy itself. But you'll find that the dementia of HIV encephalopathy, the patient is always conscious. Whereas with Creutzfeldt-Jakob disease, they lose consciousness. It's interesting to talk to patients who have HIV dementia. You say, hello, Sylvia. Oh, hello, doctor. And then after 5 minutes or so, you say, man, Tsakufatso, how are you doing? She says, no, I'm okay, doctor. She's Sylvia. She's Tsakufatso. Tom, how are you doing? I'm doing well, doctor. And then the next minute you say, Jim, you have a problem. Jim has forgotten that he was Tom before. So this is HIV dementia. They forget, they go to an extent of forgetting their names. They forget. That's HIV dementia. But they are conscious. They are talking to you. There's no problem. Whereas with Creutzfeldt, Jacob's disease, because they lose the neurons, during the course of the disease, they tend to, they lose their consciousness. So that's the basic difference, that they'll be similar in other areas, but they lose their consciousness. The Creutzfeldt, Jacob's disease. This is something that we need to sort of emphasize. I remember I said we lose vision because of Toxoplasma gondii, Toxoplasma gondii, and it causes Toxoplasma encephalitis. The same way as you would have your cytomegalovirus retinitis causes blindness. In this one, it will also cause blindness. But with this one, Toxoplasma encephalitis, you can make out and find out it is this and it is not cytomegalovirus retinitis. How do you do that? You do it by you check for antibodies against the toxoplasma. Antibodies. Which antibodies are you going to pick up? I'm going to pick up the IgG all the time. Because if I don't pick up IgG, or I don't have any antibodies against this Toxoplasma gondii, I don't have any antibodies, then that militates against the diagnosis itself. It's not Toxoplasma, it's something else. That's why you have to go on. Is it syphilis? Is it what is it? Is it cytomegalovirus? Because they all cause the same thing. This one, you will make out that it is Toxoplasma encephalitis if there are IgG antibodies. There must be IgG antibodies. If you are able to isolate those from blood, even from the CSF, right? You are able to isolate IgG antibodies. Then you are cocksure that this is your Toxoplasma encephalitis or Toxoplasma encephalitis. This is good. It's good to know. It's good to know that. It's good to know that because. But how do you treat it? How do you treat it now? Clindamycin, 1200 milligrams daily. Actually, if you give it intravenously, you can give it 6 hourly. Intravenously, 6 hours. Clindamycin. What else would you be able to give? There's something called folinic acid, 10 milligrams of folinic acid. You will be first class. This is how to handle it. You've already established now that I've got the IgG antibodies. I've got the IgG antibodies. You've established that this is toxoplasmosis. You know that this is now toxoplasmosis, and that's why you confidently give your clindamycin. You give your clindamycin 500 milligrams, intravenously, and you get them 6 hourly if you're doing it intravenously. And then you can give your folinic and it's 10 milligrams daily. You know, I can tell you, you'll have treated this very, very, very well. These are some of the things that really we must make sure that we sort of get, and if you're slow about trying to understand it and whatnot, I can tell you you'll be okay. Rush over it and all that. I would like to go on just a little bit. Just a little bit. When you are doing that ocular syphilis, you will notice that you get something else. The eye has got an iris, and adjacent to the iris it has got a ciliary body. And when there's ocular syphilis, you'll notice that you get inflammation of this iris and inflammation of the ciliary body. They call it cyclitis. You know, this is iris. Cyclitis. And so it's just inflammation of the iris together with the inflammation of the... And it goes on. Not only that, you can get an optic perineuritis. If you get an optic perineuritis, and this is all under ocular, the ocular syphilis. You can get a retinitis. You get it. You know all these inflammations, and these they plummet down to loss of vision. They plummet down to loss of vision, and this is something that you have to. You know, if you take them one by one, you get to understand them. You take them one by one, you know that, what am I dealing with now? I'm dealing with the ciliary body, and I'm dealing with, adjacent to the ciliary body, there's iris. And then inflammation of the iris and the ciliary body. Oroidocyclitis. And that's just the inflammation of that. And then you can go now to neuroretinitis. You go on to to all of them, to the neuritis and optic. We call it optic perineuritis. Those are all inflammations of the eye, and this is bad news because the middle layer of the eye is known as the uvea, and then you get a uveitis. Do we still expect this eye to see? This is a big problem, and I would like, just to make sure that people understand which are the crucial areas here. I really need to know my crucial areas, that I will lose vision for as long as I tamper with the retina. I want you to take that one home. And that is why cytomegalovirus retinitis is a causal or an etiologic agent of blindness. Patients go blind. ocular syphilis is the one that will give rise to even syphilitic meningitis. So I still expect my patient, when the treponema pallidum is right in the eye, I still expect, and not only just in the eye, but it is in the retina, the light sensitive layer of the eye. This, I'm expecting a bit too much to say that this patient will be able to see. And that is why it is important now to treat the conditions which give rise to this. Like the HIV that has gone right down. In other words, the CD4 count that has gone right down because of HIV. And so this is a big problem. So the importance of making sure that I treat my HIV is because of that. I don't want to get to CD4 counts which are going to precipitate the advent of what? Of cytomegalovirus, so that I get a cytomegalovirus retinitis, so that I get an ocular syphilis, so that I get a PML. You know, a PML. These are things I wouldn't like people to forget. A PML is what? Progressive multifocal leukoencephalopathy, where there's a demyelination of the cerebral hemisphere. The cerebral hemisphere, the white cerebral hemisphere, it's demyelinated. I've got patches right around. It's progressive, and this patient can go to an extent of, they go into a coma. They go into a coma. And from a coma, what do you expect? I mean, death. I mean, this is not the right thing to do. Or really, let's make sure that the partnership between HIV and polyoma, polyoma virus, or this JC virus, this is not what we want. This is not what we want. We can control HIV. We can control HIV, that's for sure. We can control HIV. We've got our drugs and problem. We can control it. We can make sure that we don't even get that HIV. Right. So using all the protective measures and all that, the condoms and the rest. We can. This is wonderful. If you say, I want to target and make sure that I don't get a this polyoma virus, you don't get, you don't get it with immunocompetent patients. But immunocompromised patients, that's when you're going to get it. It surfaces, that's when you're going to get it. And it's coupled with what? With HIV. And of course, HIV, when the CD4 count has gone right down. So a lot has not been done if that situation prevails. A lot has not been done. This is a problem. So those are some of the things I would like people to... We don't want to get to a stage of a syphilitic meningitis. We know that a syphilitic meningitis, you get to that stage because what did you do? Mismanagement of early syphilis. So the change of getting early neurosyphilis, it's because of mismanagement of early syphilis, normal syphilis. Remember, we shouldn't even get that syphilis. Remember treponema pallidum. Treponema pallidum, sexually transmitted and all that. Treponema pallidum. That's a problem. That's a problem. So we don't even want that. We don't even want that. So we are saying, let's not get this partnership. Let's not get HIV, because now I'm here as a healthcare worker. I mismanage early syphilis. So what's going to happen? there's going to be early neurosyphilis. There's going to be early I've got two factors that I've used here. I mismanaged early syphilis. In other words, primary. It's easy for primary to go to secondary. It's easy for secondary to go to tertiary. And I know that in all three, primary, secondary, you can get neurosyphilis. In other words, neurosyphilis. So neurosyphilis, the probability of getting neurosyphilis with primary is high. The probability of getting neurosyphilis you get it at any stage. You get it. But there's something that you can do. You can treat the syphilis itself. You can treat the syphilis itself early and treat it well. No mismanagement. In other words, you give your penicillin well. And you wouldn't even get a chance of having to use the amoxils and the ceftriaxones and all that, the rosafins and all that. You knew that because now you've treated it, you've managed it well, you've managed syphilis well. This is something to be taken home. This is something. Tell yourself that I'm going to treat my syphilis well, to make sure that there's no inadequate treatment of primary syphilis or early syphilis, so that there should be no conversion from ordinary syphilis to become neurosyphilis. You know that if you go to neurosyphilis, you are going to syphilitic meningitis, which is sad for the patient. Really, you don't want that. Who will stand a stiff neck? Who will stand a severe headache? Who will stand the vomiting? That's nonsense. You can't stop. Who will stand that? Those are the areas you don't want to get to. You don't want to get to those areas at all. Who will stand the papilloedema coming? Who will stand the papilloedema coming from an increased intracranial pressure? Increased intracranial pressure will give rise to papilloedema. Do we want that? We don't want that. I want to thank you very much. For listening to me today. And I hope I will come with something else which emphasizes one thing. You'll notice that with my presentations, in all of them, I emphasize the role played by HIV in changing the face of medicine. The role played by HIV in changing the complexion of medicine. Thank you very much. Bye-bye for now. We'll talk sometime.